Welcome and welcome to our ground nose with our distinguished visiting professor, Dr. Damiano. I'm going to invite Dr. Gallegos to introduce him. First few announcements. I want to welcome Dr. Nate Foji, our new minimally invasive surgeon at Lakeside of Midlands. Dr. Foji, welcome to the Department of Surgery. You want to stand up? Yeah. Dr. Foji will be doing elective and emergency general surgery at Lakeside and elective surgery at Midlands. So thanks so much for joining us, and it's good to have you on board. Also, Dr. Clark, thanks for stealing our thunder. Where is Scott Reitz? Disappeared on us. He's all right, we'll wait. We'll congratulate him when he's back for his fellowship. Also, Saeed, if you want to stand up, I want to welcome Saeed. He's the first generation surgeon who's joining us from Kansas, and Dr. Walters will introduce him. Welcome to the Department of Surgery for the next 4 weeks. There he is, Dr. Reitz. Please congratulate Dr. Reitz. He matched at the University of Washington, Seattle for colorectal fellowship. Yes. No pressure. We're going to be asking you all the colorectal questions, Dr. Reitz. Yes. Dr. Walters, I'd like to invite Dr. Walters to talk about a tradition that he started. Thanks so much to your vision and leadership. Dr. Walters has introduced the Chair of Surgery coin for residents who went above and beyond, along with Dr. McCall. So I'm going to ask you both to introduce the award and the awardee.
Thanks, Dr. Al-Rafai. Welcome everybody to Grand Rounds. Welcome, Dr. Damiano. We have a tradition that we've started here thanks to the inspiration of Dr. DeRosa. I learned about challenge coins. I don't know how much you know about it, but as I've explained here before, challenge coins have been minted for thousands of years as a reward to people for outstanding effort in battle or other events. It's used by first responders, police, etc. And so we've decided to make a coin to honor people in the residency who are doing what is felt to be above and beyond work. So in the 4 months since the academic year has started, we've heard one name over and over again this year. And so this chair coin is going to go to Rodonis Grissom. Dr. Grissom is really setting the mark for academic teaching. All right, that's all I got. Sure. So just as a note, Dr. Grissom joined us last year as the first generational award recipient, where he came to spend a month with us, just like Saeed is doing now. He got to see sort of how the services run. We got to see how he ran, and it worked out great for us and hopefully for him in terms of the match this year. So Saeed, welcome. We hope that may be your journey as well. And thank you, everyone. Okay. Yeah. All right. We want to get a quick group photo. Okay. Congratulations.
Good morning, everybody. It's my distinct pleasure to introduce Dr. Damiano. First, I'd like to, before everybody leaves, to remind folks that there will also be time after Grand Rounds. We're going to be going upstairs to the second floor for a educational simulation session with both with Atrial, and we also have some hearts available for anybody who wants to try their hand at some valve implants. But first, let's start the morning by having Dr. Damiano give us some insight into the world of cardiac surgery. Again, Dr. Damiano is pleasure to invite him up from WashU. He has served as the everyday Graham professor and as the past division head of cardiac surgery at Washington University. If I were to give you an entire list of his publications, it would take the rest of the time we have. But I'll start by saying been a leader in the development of arrhythmia surgery, working with Dr. Cox to not only develop, but to continue to develop the world of ablation surgery and influence the treatment of atrial fibrillation over generations to come. He started his training up in the Northeast, completed his training in medical school at Duke, and then trained under Dr. Cox and continued to develop what is now the accepted, what I would call the gold standard of surgical ablation for the treatment of atrial fibrillation. He continues to educate those and influenced a few people, including our own Dr. Chiamani, who joined us. And I would say he continue to do that into the future. I look forward to his discussion today on the current state of surgical treatment of atrial fibrillation. And again, I'd love to list all of his accomplishments, but I really would love to hear him give us more information. So, Dr. Damiano.
Thank you. Well, good morning. It's great to be here, and I really appreciate the invitation, Dr. Arafai, to this great department here with a long history. We have our own present chief of thoracic surgery in my division, and what was as division chief, Dr. Varun Puri, trained here and speaks extremely highly of both the people here and the training he received. I'd like to talk to you this morning about surgical treatment of AFib, and for general surgeons, this may seem quite off topic, and I hope I don't totally bore you, but feel free if anyone has any questions to interrupt. I would tell you these are my disclosures, but before I start, I'd like to really point out that this has been the result of decades of both laboratory research and clinical research by our team. This just shows the present group that we have in our laboratory looking at surgical treatment of arrhythmias, and really it's a multidisciplinary team. But I hope to illustrate the power of translational research and the importance of surgical sciences in progressing our field. I think that is applicable to every branch of surgery. And I think this I will show you is really a great example of why we can't ignore our responsibility and really history in surgery of really doing excellent translational research and really discovering new things. I've been at WashU for 25 years, and I've had the opportunity in my lab to train over 80 research fellows, and I would say, and I will talk a little bit, we've also had over 40 years of continuous NIH funding of an R01 that's not changed its name now in over 4 decades, which I think might be close to a record. But I hope to show you that what that has meant in the field, and that this wasn't research, people talk about, you're just a lab jockey, but this directly impacted the field, and many of our research fellows have seen
Yes.
clinical practice. So it just shows you the power of that. But I would also like to acknowledge Ali, who is one of my fellows. And this is a picture when he finished at our house, where we have the end of the year celebration for our fellows, and we're extremely proud of all he's done. And I always tell all my fellows that my favorite, but Ali was one of absolutely my favorites. Did an excellent job. I'll show you some of his work during my talk. But like I said, the surgical treatment of AFib, you may say, well, why the heck is he talking? And many of you probably are looking at seeing if your pager will go off in the next 5 or 10 minutes. But I think it is a paradigm of translational science leading to surgical advances. And I hope to show you at least briefly, I want to try to review the whole field too, but that laboratory research really provided the foundation for clinical innovation. I would say for safe clinical innovation. Anyone can innovate. But the question is how you do that safely with the patient's interest always first in mind. And it allowed for us to go in a stepwise progression. We won't be able to show you all of that this morning, from a hypothesis to laboratory experimentation, bring it to the operating room, and very critically, and this is where surgeons are very important, coming back to the lab when you find out that, yes, well, this operation, and I will say the maze works fantastic in dogs and pigs, not so great in humans, and we did take a lot of what we learned in the operating room and on the wards back to the lab to try to improve devices. We'll refer to some of that. But if you look at this as one R01, it developed an entire field of surgery. But more importantly, this R1 developed the first interventional treatment for AFib, which I'll show you is the most common arrhythmia in the world. And that was done a decade before catheter ablation, which now everyone's very familiar with. But this was, at the time, there was no treatment, was not felt to be an arrhythmia that was at all amenable to any type of treatment, yet this is what came out of the lab. We also developed the first minimally invasive procedure about 10 years later, and then spent over a decade testing and verifying efficacy of ablation devices. And I'll explain a little bit of that as we go in, and introduced the maze, the fourth version of the maze we introduced in 2002, using the most effective ablation devices which we found in the laboratory. And even now, more than 2 decades later, it's the only operation that's ever gotten FDA approval for the treatment of AFib, including none of the original versions of the maze ever got approval. So it's an important aspect, I think, for everyone to realize the impact you can have doing translational research. And more, not only was it important that we did a lot of work in experimental models, but we also continuously evaluated our clinical outcomes with an extensive longitudinal database, which we've had again since 1987, and have had a dedicated both AFib coordinator and clinical research team. And I probably can't emphasize the importance of that, you know, your innovation doesn't stop, you know, when you finally introduce an effective operation, but it really requires careful evaluation of your clinical results to allow for continuing evolution of techniques. So just for those of you who are not familiar with AFib, or probably have heard about it, you probably have a grandparent with it. It is the most common arrhythmia in the world, over 5 million patients in the country, and the prevalence is expected to double in 2030 as a whole by 2050. And 2% of the world is affected by it. And if you live to 40, you have about a 1 in 4 chance of developing AFib during your lifetime. So it's incredibly prevalent. And most importantly, though, not only is it prevalent, but it's bad. It increases your stroke risk by about 5-fold, your chance of going to heart failure by 5-fold, and it gives you about a 46% greater risk of dying than if you didn't have AFib. Importantly, the 5-year survival, once you're diagnosed with AFib, and hopefully none of you have it, but usually it's very elderly people, so I'll put that in perspective. But once you're diagnosed with AFib, your 5-year survival is about 50%, which is worse than a lot of cancers. So it's a very morbid diagnosis with a lot of problems. So, you know, obviously a really important medical problem in the US, a huge amount, billions and billions of dollars spent each year. But let's go back first before we start. You know, where were we in the early 1980s, which I think is going to be before many of you in this room were born. But at that time, when we were starting to look at it in the lab, it was AF was felt to be this chaotic arrhythmia. It was not amenable, and it was definitely the accepted wisdom, and there's still some people who think that it isn't that amenable, but it wasn't felt to be amenable. It was just treated with drugs. And drug therapy at that time was really ineffective, and I would argue it probably is still today, and plagued by a lot of side effects. And most patients actually were treated, when I was a resident early faculty, they weren't even treated with antiarrhythmic drugs. They were felt to have so many problems. People were just given blood thinners, Coumadin at that time, and now DOACs now, and rate control. So we had a history of treating arrhythmia surgically. All of them now are treated by our EP colleagues in the cath lab, but WPW, AV node reentry, arrhythmogenic right ventricular dysplasia, all those we had come up with surgical procedures, were then left to very effective catheter procedures. But we did it by defining the mechanism first, and then devising an operation. And that was the sort of stepwise process we did. So back in the early 80s, we first tried, could we define the mechanism of AFib? And it was a bit of a long shot. And then see if there was anything we could do. Because obviously this was the holy grail of arrhythmia surgery, because it's the most common arrhythmia. So we developed a mapping system, which we still use today, both in people and in animals, where we could try to map at first clinical AFib patients coming to the operating with AFib, and then see if we could figure out exactly what caused it. And this is just a look of how we put these electrodes on the heart. We've progressed somewhat from these bare wires there, but it's still pretty crude when you look at it, though we do have now flexible integrated electrode plaques. But we were able to map AFib, and this is from Dr. Cox's first paper in 1991 when he kind of introduced the idea. And it's interesting when you look at it, the focus for this patient, which is the first description of the procedure, was in the right atrium, and I see some of the EP colleagues were here. It was not in the left atrium. But it was way too complicated. And what we found from that was we couldn't figure out the mechanism. Not only was it incredibly complex, and there was actually multiple mechanisms in the individual patient, often up to 5 or 6 different areas we could feel like, well, that could be AFib, that couldn't, maybe that could be. There were lots of what we now know were probably micro reentry, and we won't get into it. It's a whole other topic of the mechanism of AFib, of which we still, in 2025, for those of you who are interested in trying to continue to do this, we still know very little about it in the individual patient. But not only are there multiple different mechanisms, but if you mapped at one point and then came back either 5 or 10 minutes later, they totally changed. So it was changeable. We could not define a target for a procedure. So it's important to remember, first of all, and we can even say in 2025, I just gave a lecture that said we have zero idea. And I think Natasha DeGroot was there for electrophysiology also talking. And the consensus is that in an individual patient, we can't define a mechanism very rarely, especially in long-standing persistent. But it was defined, this was developed as an anatomic operation to treat all types of AFib because of that. So we said, okay, forget about it. We'll try to stop all AFib. Now, here is where it's important to be a scientist, as we say, better to be lucky than good. The interesting thing is our theory of what AFib was then, we now know is completely wrong. So we thought there were multiple big macro reentrant circuits that thought to be responsible for AFib. So Dr. Cox and a cardiologist, Dr. John Boyneau, and an engineer, Rick Schuessler, who just recently retired from running our lab, came up with an operation. The idea was, can we stop this? Can we block this with incisions? And it was John Boyneau had the really, I think, brilliant idea that these reentrant circuits, we knew that a flutter rotated around the mitral and tricuspid valve annuli. And his feeling was that all the holes in the atrium were potential macro reentrant circuits. So he which turns out to be fortuitous. We isolated the whole back left atrium because but really just were trying to isolate the orifices of the pulmonary veins. We didn't at that point know the importance of pulmonary vein triggers. And the same thing with the cava and the 2 valve annuli. Interestingly, in 2025, we would say we have never been able to map a stable macro reentrant circuit, ever. I really don't think they exist. You can see a macro reentrant circuit, but it moves, it changes, it's not stable. When you come back, 5 minutes or 5 months later, it doesn't exist. But interestingly, so we were wrong with the theory, but we first tested it. We developed this idea. You'll see the operation is quite invasive, but we tested it in various animal models of AFib to establish that it worked and was feasible for introducing it clinically in 1987. So the importance of first making sure, one, we wanted to make sure that it didn't destroy your atrial function, which it doesn't. It turns out that animals, it's too bad we all don't treat animals with AFib because it's a very fragile arrhythmia that can be treated with almost anything. So the reality was almost any operation probably would have worked on the dogs and pigs we looked at, but it did. And then this is the operation was introduced. It's complicated, and it was a set of incisions on both the left and right atria that block things from rotating around the valve annuli, the cava, and the 4 pulmonary veins. Which sounds like, well, that's not too hard, but it was. And actually, in the original procedure, both appendages, we don't do that anymore because that causes some set of problems. But So it was called a maze because the cartoon, and when you did it surgically, you felt like you were creating a maze of incisions on the atrium. And lo and behold, we were wrong of the theory that we were trying to prevent. But what did we learn? We learned it worked. And this is from the first, 200 patients that were done in St. Louis. And we looked at, this is a follow-up at almost 7 years. And 80% of people 7 years later said they were in an AFib and they were off all the drugs. And this is pretty startling. If you can remember, this is an arrhythmia that was felt to be untreatable. So it did prove the point that we were wrong. It's a treatable arrhythmia. So that's the first thing we learned. So that's where I say it's better to be lucky than good. So it worked. It probably worked for a different reason. I will go into that a little bit later in the talk. But it worked. And now you can see back in these days, this was in the 80s and 90s, there was really we just called the patients and said, are you an AFib? And that was how we decided. That's why I said symptomatic AFib. It's interesting now the guidelines are coming back to this as an important endpoint. It turns out that once we use prolonged Holter monitoring, you'll see, which we do now, the results are very similar. But you can see 80% are free. Only 4% said they were an AFib. Another 16% were on antiarrhythmic drugs. So we assumed they had recurrences, but we didn't really. But, I think they should be kept apart. But it's interesting. It worked. But this is the interesting thing. No one did it. That's the other thing we learned. It was a great operation, but no operation, whether it's, in colorectal or hepatobiliary or cardiac, if only a couple people in the world can do it, it's not a good operation, right? You have to be, it has to be translatable to the entire field. And this was not either the Maze 1, 2, or 3. There were 3 versions. And only several hundred procedures were performed worldwide each year as of 2000. And it was so rarely performed that it wasn't included in any of the big national databases in cardiac surgery. There was no column for arrhythmia surgery. Most of them were done at about 3 centers in the US and about 3 or 4 around the world. But last year, actually this is from a year ago, it's about 60,000 ablations were performed worldwide. So what I'd like to do is kind of review to you also the work it required. So we came up with an initial idea. It worked. We still, I would say, in 2025, we don't have a great idea of why it works, which is whenever you move or whenever you alter this procedure, you really have to follow your outcomes because we don't really know why it works. We know the critical part, which I'll show you in a little bit. But what happened? So the first thing is there were a lot of shortcomings, and I kind of showed you that cartoon, but this was a difficult operation. It took Dr. Cox, who developed it, an hour and a half of extra cross-clamp time to do. But that wasn't the whole procedure. It took about 2 hours of total time. And if you're adding that to complex other cardiac surgery, no one would do it. And a lot of people, in fact, very few people did it as a standalone procedure. And there was, as you can imagine, any operation that took that long on bypass, cardiopulmonary bypass, there was some morbidity. So our group and others, we went back to the lab and said, okay, we proved the concept. Now, can we do this in a much less invasive way? And our hypothesis, and this is a good example, it was the proof that the Maze procedure worked that led to the development of catheter ablation. But then we realized, they're doing this all with catheters, maybe not that as effectively as the surgery. Can we use ablation technology to replace surgical incisions and make this something that everyone can do? And that took us about 10 years of research to work out. But the challenge was way more than we first thought. And it's also good, you have to be an optimist if you're doing translational science. And it's great to go in thinking this is going to be easy, and it never turns out to be that easy. But we had to find something that reproducibly and consistently made a transmural scar. I mean, cutting something and sewing it up is fantastic. It's right transmural. It's invasive, but we were trying to do that with an ablation device very quickly. So we spent quite a bit of time. Initially, if you go back 25 years, these are all technology that were being talked about for trying to accomplish that goal of creating transmural scar. And almost all have fallen by the wayside. We're left with only 2, which is bipolar radiofrequency and cryoablation. All the rest have been shown to be ineffective. And that was a big initial impetus in our lab, was trying to do that. And this is just a review paper we published in Heart Rhythm in 2009, really detailing the incredible difficulty of trying to create transmural scar, particularly using epicardial ablation. And most devices, in fact, almost all the unipolar RF, laser, high-frequency ultrasound were completely ineffective. And there's a lot of reasons, and I won't go into it a lot, but it turns out that creating a scar across the atrium is really difficult because the atrial wall thickness varies from less than 1 millimeter in some areas to over 2 centimeters thick in others, depending, if you're a normal person versus you have valve disease. So you can imagine if you're using an energy source to kill tissue, how do you try to compensate for that fact? I mean, how do you're looking at it, and when we looked at the power it takes, it's almost a 40-fold variation in electrical power, and it's a problem that I think you have in the lab too. Is that, it's very difficult, and even a little tiny gap, and we've showed this in the lab, if you miss a 0.5 millimeter, it's like, in fact, it's worse than creating no line at all. So, so first of all, we had to be 100%, and we couldn't miss any spot, and that turned out to be very few devices can do that. I'll quickly go through what we found. But the other thing is that the advantage that I see some of the electrophysiologists there, there's no fat inside your heart, which is fantastic, and like catheter ablation is great. Unfortunately, most of us have a lot of fat, and I can tell you after, thanks to Ali and the dinner last night, I probably have a lot more fat around my heart now. But fat is an incredible insulator, and it's impossible for us to get any type of thermal source or thermal energy through fat. And finally, we have the issue of the heat sink of the circulating intercavitary blood, which, you're basically, the problem is not your atrium is full of blood and we're trying to ablate all the way through it. The problem is it's circulating at your cardiac output 4 to 6 liters per minute, and it's an incredible, whether you're trying to freeze it or heat it, you cannot get full thickness, which is a huge drawback to a lot of devices. So, and this is just I won't go, but this is just a look at the varying of the left atrium. You can see here in cross section. This is probably the most arrhythmogenic part of our atrium, which is the posterior left atrium, where your pulmonary veins and lateral ridge are. And it's just crazy. This is what it looks like just looking at it. This is in cross section. You can see how thin, when you transilluminate, you can really see through the atrium. It's an incredibly complex structure. It was very difficult to figure out. But what we did find were these are the 2 clamps that are on the market, and they both work, but they deliver, you clamp the tissue, which flattens it out, which gets rid of the variability in wall thickness. And then you deliver really focused energy between electrodes embedded in the jaws of the clamp. And this is just a close-up of one of the clamps, which has a dual electrode. It doesn't matter, but you're really focusing the energy. And it turned out, now you can imagine this is a big clamp. We're not putting, you can do this thoracoscopically, you get it, but it's not really amenable to off bypass for most of it. But it created crazy scars, and this is a Mason's trichrome where blue is scarred. You can see these are 3 millimeter scars, and it was, as I said, I wish animals got AFib because it really works fantastic in animals. And we've done 5 chronic animal studies, over 1,000 histologic samples, and every time, 1,000 times with one ablation, it was transferred. We thought it's like a little minor miracle. Unfortunately, the human situation was quite a bit more complicated, so that was good. And the problem with these clamps, you couldn't do the whole maze. Very complicated. Trying to get these clamps up to your heart valves were impossible. So we went back, starting in the 1960s, cardiac surgeons have used cryo devices to treat arrhythmias. The first arrhythmias were treated that way. And some of the original cryo probes are shown on the left here, which are reusable, and now they're all disposable. But we tested those, and we knew from previous experience they were generally good, but when we actually went to the lab, and this is how we test devices, we look at the tissue thickness versus the ablation depth. And obviously, if you have a perfect device, everything lines up on this line of unity, which all the histologic specimens for bipolar RF, but cryo was good. It was extremely good. You can see we missed on one segment. This is the disposable device, again, in a very thick piece of tissue. We didn't quite get transmural. But this technology is about 99% of the histologic samples are transmural, which is about what you need to be 100%, close to 100% reliable. You can't really get much below 99%. So we took both of those devices, which we tested in the lab, and we introduced in 2002. The paper was in 2004, but we introduced this. We used those to replace most of the incisions, and we were left with 1 or 2 incisions shown in green, but the rest were done with these clamps. Or you can see at the valve, in order to not injure valve tissue, we use cryo at both the mitral and tricuspid annuli. But basically, it made it easier to do. And I would have to say the good thing about when you test things out, it turns out even today now, it's the only operation that's been approved to treat AFib. And with that operation, the FDA said you have to use this technology. You have to use it. So they approved both the operation and the technology. That's it. And still, there's no other devices approved for surgical. There's one hybrid procedure that's been approved. And that's because all the other devices, all the other operations didn't work or were not translatable. These were all proven that they were efficacious in multi-center prospective trials. And this is the first report that we did of that procedure of the first 40 patients we did. And, you know, this is what the cartoon looks like. And we can do it minimally invasive. Most of you who do laparoscopic or robotic surgery may not consider most of what we consider cardiac that minimally invasive, because it does require being on the heart-lung machine. But you can see on the left side is the sternotomy, but it's not really important. But you can see, you know, here we make a small atriotomy and do the rest with the bipolar, which is in red, and then freeze down to this is the tricuspid valve. And I won't really go into it, but this is what the left atrium looks. And we could do these through 2-inch incisions. We use high definition endoscopes for visualization. And, you know, certainly anybody who's really interested, I could show you movies afterwards. But this is it's a combination of using these clamps and cryo. We took the time it took to do it from 90 minutes to about 25 minutes. So that was a huge advance. And we took a huge amount of the morbidity out of it. And this is how we do the minimally invasive. It's a small submammary incision in women over the 4th interspace in men. And this is a patient of mine. You can see the incision from here to here. He had a maze and a mitral valve repair. So it could be done, you know, there's a lot that goes into that, which is a whole nother talk. But we took an operation that required a sternotomy and 2 hours down to something you can do through a 2-inch incision in, you know, 25 to 30 minutes of ablation time. It took, as you can imagine, it takes longer. So next, though, so we were able to adapt it. We showed, I won't bore you with a bunch of publications that using ablation technology, we called it a maze 4 to differentiate it from the cut and sew maze of the maze 1, 2, and 3. So first, then you have to prove, does it work? Did I compromise the operation? So I'll look at you about 20 years of data. It works. The concept is great. And the fact, so how does it work at restoring sinus rhythm? Works really good. This is Dr. Kamani's publication from several years ago of our 853 consecutive patients that we did this procedure on. And they were all comers. 60% had the most difficult type of AFib to treat, long-standing persistent AFib. So this is what you have to do, is go back and look, and this is what we found. Now, if you look, these are all comers. These are people who had triple valve procedures or CABG ×4 and a mitral tricuspid repair. These are not, I'll show you just the results in lone AFib, which are quite a bit better. But these are people with extensive disease, multi-system cardiac disease. But you can see at 5 years, 84%. Now, it's interesting. If you look, remember I told you just asking people, are you free of AFib? It was very similar, but all these patients, on the other hand, had prolonged at least 24-hour Holter monitoring every year in follow-up. You can see it not only it works, but it's pretty durable. And you can see even out at 8 years, we had 83%. Now, and I'll show you some more data. The more rigorous way is to say you're both free of AFib and you're on no antiarrhythmic drugs. And you can see that's a little bit lower. And that's how we found out one of the real problems with the maze 4. But whatever, in every patient, it worked great. And which was in distinction to catheter ablation, it works equally well in paroxysmal and non-paroxysmal AFib. And this is just looking at time to recurrence of both of those. We found no significant difference. We recently, with even larger numbers, there's a slight trend toward better outcomes in even this study with paroxysmal, but at least in this study, really no difference. But that's because, again, it worked. It treats pretty much all types of AFib, whether you have 20 years of AFib or you have 2 months. Now, if you look in the lone population, take out people with a lot of other cardiac disease and heart failure, it works even better. And this is 236 patients published also about the same time of lone AFib. But you can see, I probably won't go, we had, with taking it from being a big open procedure to a smaller procedure, we've had no mortality with the MACE-4. We just haven't. There's morbidity, but the morbidity was half what we had seen with the MACE-3. So the outcomes were good, but if we look at the results in lone AFib, at 10 years, we have almost 90%. And this is the great majority of long-standing persistent. The median duration of AFib, see an electrophysiologist, was 7 years. And the median left atrial diameter was 4.8 centimeters, which most people, a lot of electrophysiologists don't like to ablate people over 4.5, but that was the great majority of our patients. And 2/3 had failed at least one catheter ablation. So it proves the concept that if you can actually get a durable lesion, it seems to be effective. I think, it's interesting, but you can see it's not perfect. And, even as a surgeon, to have 1 in 10 people fail, which is what we do, it still feels bad, but it's actually quite good. But the other thing we found is not only did it restore sinus rhythm, and this has become now apparent in some of the large electrophysiology studies, but it improved survival. And I'll just show, this is a paper we published a number of years ago, and we took patients coming for other cardiac surgery who had AFib, who either got a concomitant MACE or didn't. And then we had to propensity match because there's clearly selection bias there. But we were able to get quite a good group of patients that we were, 342 patients, all had AFib coming in. We matched them for 22 variables, which we knew that affected late survival. And then we just compared them and see how they did. And this is the impressive finding. At 10 years, we had a 20% survival benefit. Now, if you remember, for the cardiac surgeons, a left internal mammary to the LAD has only a 10% survival benefit at 10 years. This is twice it, yet still most surgeons don't treat AFib, which is crazy to me. But you have to not only treat AFib, but you have to treat it and get success to get this kind of. And this has now been, after we published this, numerous others have published this. This is a much larger study from Europe and from a bunch of European centers where they did the same thing. But here now they've propensity matched over 2,700 patients in each group and looked at survival. And again, if you had ablation shown in the red, you had lower mortality, significantly lower mortality out at 8 years. And that's now held up in large other databases. There's never been a prospective surgical trial because unfortunately it took us so long to sort of perfect this. At least I do not have equipoise to be able to do that. And it also prevents stroke. I'll kind of go quickly through that. But part of the MACE, really from the beginning, and why we were pretty unique, is we really felt we had to manage the appendage. So every patient had their appendage either cut off and oversewn, shown on the left, or now we use this clip, which is nice because it's a lot quicker. But we found a very low risk of stroke. This was a paper from almost 10 years ago now that we looked, and we followed 433 patients for about 7 years. We just saw no strokes, even though the CHA2DS2-VASc score was over 2 in the majority of patients. And we had no association of stroke to CHADS or warfarin use. I probably won't go through that, but we have some very much better evidence now. And this is from a couple of years ago, the LAOS 3 trial, where they randomized people to either getting their appendage clipped or not. These are all patients with AFib. And again, a mean CHA2DS2-VASc score of 4.2, which is how we, anything over 2 means you have a pretty high risk. But you can see here, this looks at the cumulative incidence of stroke or systemic embolism. Occlusion is shown in blue, no occlusion, no appendage occlusion in red. And you can see over 2,300, one of the largest randomized surgical trials ever done by Richard Whitlock in Canada. And you can see significantly improved outcomes with appendage occlusion. So then the question goes, okay, can we use a more limited lesion set? And then again, this was right after in the late 90s and early 2000s, Michel Hasseguer described the fact that pulmonary vein triggers were really important. So then we thought, could we make it even simpler? Does the whole maze really need to get done? And as Albert Einstein said, yes, it's going to be simple, but not too simple. And pulmonary vein isolation turned out to be too simple. And this was introduced by Randy Wolf back in 2005. And it's so simple with these ablation clamps is you just put them around the pulmonary veins. You know, you're done. You can do it thoracoscopically. It has some risk to it, as you can imagine, off pump particularly, but easy to do and reproducible. Unfortunately, it didn't work. And the long-term efficacy has been very poor, both in our center and others. But our initial experience with the Maze 4 definitely showed why it didn't work. And I'll show you this. So what do you mean by pulmonary vein isolation? I just showed you where you clamp the pulmonary veins. The original Maze 4, we did, instead of isolating the whole back left atrium you see here in C, we just did this. We just put one connecting lesion, because I was convinced that the theory at that time was these big macroentrant rotors, even though we hadn't really seen any, and I just needed one ablation line. So I thought, well, we'll make it a little bit simpler. That turned out to be a really bad idea, but we learned a lot. And now we always do C, which is box isolation, which is really now, I think, the foundation, probably more of the foundation for certainly surgical treatment, and a lot of electrophysiologists are coming over to this. But what are the best outcomes? So when we first did the Maze 4, as I said, we did the whole lesion set. There's 13 or 14 ablation lines, except I left out this one line. That's superior connecting lesion. We did everything. A whole right and left atrial lesion set, clipped everybody's appendage, did, flutter lines on both the left and right side, and the whole thing. But we realized about 5 years in that probably wasn't a good idea. And this is the data. It took us a lot of patience to figure it out. You can see we introduced in 2002. We realized it about 2009. This was when we finally had really good statistics with a much larger patient group. You can see this is freedom from arrhythmias off drugs, but you see it cut the success down in half at 5 years. These ablation lines take 20 seconds to do. So we saved 20 seconds and we cut the procedure right in half. We've learned a lot because we learned pulmonary vein isolation, which we had in everybody, and we document exit block in every patient. It didn't work. So you knew that the best you could be would be 33% successful with even less. It turns out it's even worse than that. And I'll show you some data on that. But similar to the EV lab, where directed pulmonary vein isolation doesn't work, directed and focal pulmonary vein isolation surgically didn't work. But again, if we didn't follow our patients, we didn't. And to be honest with you, I kind of had a feeling that it wasn't working, but I had no idea it was as bad as it was until we looked at the data. So it's really important to monitor your clinical outcomes. You can often learn a lot. And in fact, it was our observation that really led to the development of the present clamp. There's now a clamp that just does a box as the only procedure. So that hypothesis has not been proven. We proved if you don't isolate the whole back of left atrium, the maze doesn't work. And you'd have to argue that an operation that fails, 2/3 of the time, 5 years, not something you want to probably be doing much, nor will a lot of people sign up for it. This is just some other data, and I'll just quickly, where they compared PVI to a Maze 4. And this is actually not, there's nothing huge in the literature, but this is AF-free, which you can see very similar to ours at 5 years, cut the success rate in half. But if you looked at off drugs with PVI, it's 19%, even worse than we had. Because, my feeling is, their Maze results are a little worse than ours, but it just is not an effective operation surgically. And there's been a couple randomized trials where we looked at surgical PVI versus catheter, and some have shown that surgical ablation is better. Others have shown that it is. This is a randomized trial looking catheter versus surgical. So I'll just say that, that's the trouble of trying to make things too simple, particularly with an arrhythmia like AFib, where we're not really sure the mechanism of the individual patients. And I'll just end real quickly with just saying that those disappointing late results have led to the development of hybrid approaches, combining a catheter-based endocardial and a surgical epicardial approach. And I know you've done some convergent procedures here, but this was pioneered by Marc Lemaire and Laurent Pizon in Maastricht. in 2009. And, you know, a lot of people have worked on it since then. Now, the advantage of hybrid, you say, why not just do a Maze 4? The Maze 4 still requires it to be on the heart-lung machine. You can do the little incision. But the idea was to do something that you could do thoracoscopically without the heart-lung machine. And, you know, the goal was if you go from both sides, maybe you'll get these transmural lesions I told you would be really hard to do. And now, but the goal of all these hybrid ablation strategies, and this comes from the latest consensus statement, are what I showed you, because what we showed is the goal is to isolate try to isolate most of the left atrium. And these are different techniques that have been used. And I don't think it's that important. And now there are 3 randomized trials that show that hybrid approaches are superior to both catheter and surgical PVI. They've all been compared to catheter PVI because I don't think very few people are doing surgical PVI anymore. But this is the Converge trial, which uses a subxiphoid or I think most people now are using thoracoscopic approaches, but this is the original, and it's a suction irrigated unipolar RF catheter to ablate, and then they come in and touch up often a lot of touch up endocardial leak, because this catheter is good at charring the surface of the heart, but as I said, it really doesn't get transmural very well, and it has to be used in a hybrid approach. But this was the original trial, 153 patients randomized at 27 sites. Again, a 2-to-1 randomization of, you could argue that then, and some cardiologists have argued that the catheter ablation arm was not maybe state of the art, but the hybrid ablation arm, and you can see, at least in this, and this is 1-year success of 53%. Now, they also defined success, it was a little under 50% if you were on antiarrhythmic drugs. But you can see the 1-year success of a lone Maze is 97%. So clearly not as good, but they weren't comparing it to a low Maze, they're comparing it to endocardial catheter ablation, and it was significantly better than that. And there's been 2 smaller, more recent studies. This is the HeartCap AF from Europe that came out recently. And this study really, again, you can see, you would probably argue that these numbers, 19 in one group and 22, hard to make too many conclusions that they have reported some late follow, but it's small, but did suggest that catheter ablation was better, that hybrid ablation was better than catheter ablation, and that's the red line. And again, freedom from arrhythmia recurrence in a month, you can see probably maybe a little worse than most centers are reporting in catheter ablation, but certainly better in the hybrid arm. And probably much better in bigger trial, all in persistent and long-standing persistent AFib, which is where they have the most trouble with catheter ablation. And this is the CSAF trial by Nico Dahl. And again, you can see here, again, the hybrid arm in blue, significantly better. So it does suggest that this is, I think, going to play a role in now 3 trials. I think, and they're starting to report some of the late follow-up in the hybrid arm is showing a more durable lesion set than we get with catheter ablation. So I'll end with that. You know, I just say, you know, it's been a very interesting journey over the years, looking at this from when I was started as a 3rd-year medical student to now. But you know, and when I look back at my career, and I would tell for all of the young people in the room, there's an incredible, I mean, I would have to say that the most joy I've gotten in my year has been patient care, but second to that has been the work in the laboratory. And it's incredibly gratifying to feel like you've made a small difference, but also to train people who will go on to make even a bigger difference, like Dr. Kabani and other people who've been in my lab, to continue to advance the field. But, you know, the Cox-Maze procedure, which we went in, 25 years ago from an operation that worked, but no one did, to one now that, it's being done. I'm sure we're going to hit 100,000 here soon of surgical ablation, but you can do it minimally invasive with very low morbidity and mortality. And unfortunately for that procedure, still referrals are stagnant, but I would say about 1/3 of cardiac surgery patients have AFib. And, we don't really depend on people referring those to it, and we need to do a good job of treating it, which is a whole nother. But I would say, like I told you, the surgical PVI, if we try to make it too simple, it doesn't work. And we're not 100% sure why the operation works. We know the posterior left atrium is important. How important everything else is, is still being determined. We know left atrial appendage occlusion is important, and we know the isthmus lines are important for flutter, but we're still sorting it out. So modifying it, I think, is an issue. And hybrid ablation, I think, has shown some promising early outcomes. Not as good as the maze, and I don't think it has much of a role in people coming to heart surgery who are going on bypass, where the maze is still very durable, easy to do with very little. Numerous studies have shown it doesn't add to the morbidity or mortality of other cardiac surgery. But the hybrid ablation are increasing, and I think that's an important part of the future. And finally, I hope to show you the field's really evolved pretty remarkably over the last 3 decades. But the progress isn't just a bunch of surgeons going to the OR doing new things. It's really required, most people I call basic because I'm a heart surgeon, but it's translational research coupled with constantly looking at your clinical outcomes, seeing how you can improve. And, I probably would also say a very close partnership over these years with industry, which has allowed us to test a lot of these devices. So with that, thank you very much for your attention. I'll be happy to take any questions.
Dr. Thank you so much for a wonderful, inspirational ground rounds, and thanks for taking the time to come from an institution that's near and dear to my heart. I've had a wonderful relationship with many people that we have in common, and for training a star here. And we want to welcome friends of the Department of Surgery, Marcy Damiano and Lena. Thank you for joining us today. Questions for Dr. Damiano? Dr. Pepitas?
What a wonderful talk. Thank you very much. There's so many clinical questions to ask, but I wanted to maybe focus a little bit on the biophysics. So you have heating, and you have freezing, and you have ice crystal formation, and you have coagulation injury. And I wonder if the method of inducing the injury makes a difference, and whether the response, whether it is fibrosis or fatty infiltration or inflammation, makes a difference in the long-term outcome. And if you're collecting tissues to answer this question, this is phenomenal work you're doing. Thank you.
Yeah, that's an excellent question. It is really a whole other talk of itself. And that's why we did a lot of all that. Almost all our work on that has been experimental work. And we never brought any device to the operating room that we couldn't both document efficacy and safety in animal studies. They're very different. Both, I would tell you, unipolar or unidirectional radiofrequency energy, really we could never get to work on from epicardia. Even with the heart, if you totally arrest the heart, you can, but it still was much more variable. It wasn't until we really looked at these bipolar clamps, which were a game changer for us. The problem with clamps is you have to clamp the tissue. So you have to get one jaw, either, you can be around the pulmonary veins and kind of put it around, or, we don't isolate the appendages, but you can with these clamps. But you can't do all the connecting lesions, and you can't isolate the whole back of the left atrium. There are some techniques that we've developed to do that, but it was hard at the beginning. And we were really trying to do the whole maze. So you were limited. We couldn't do the whole maze with the bipolar clamps, but we like them because they're still the most reliable device we ever tested. But they do result, as you say, it's heat injury. So it's coagulation, necrosis. It denatures proteins, which is not a good thing around heart valves. But it does give you a fibrous, I showed you that Mason strike chrome. We were surprised. It's a discrete fibrous scar, and there's not much of a border zone, which can be very arrhythmogenic, because it's focused delivery of RF, which is very different. It's not like your bovie. You really get a directed scar. It's a really clever device developed by an engineer in Cincinnati that I was fortunate enough to work with early. I think it's incredibly clever, but the fact that it's heat-based, you can't get it near the heart valves, and we showed that it can damage heart valves. It interestingly, acutely didn't damage coronaries. The bipolar clamp, the unipolar clamps destroy coronaries. But so we had to use another, and that's where we went cryo, and that we had a long history with, and we felt comfortable with the safety of that. Cryo freezes the difference. is it doesn't denature protein. So it leaves your extracellular matrix and scaffolding intact. It leaves your collagen intact. So it's actually interesting because it decellularizes, but then with the scaffolding intact, the heart is very good at repopulating things. So it tends to do that. And we've shown in others that it's very safe on heart valves. Not so safe on your coronaries, I would say. It would avoid freezing coronaries. We showed back in the early 80s that it causes intimal hyperplasia late. But thermal, our real goal was, and this is where biophysics comes into account, was that, our goal was to try to do this from the outside of the heart with the heart beating. But, biophysically, either heat or cold cannot do that. We did show that if you put people on bypass, even if you don't arrest them, that you usually can get transmural with some of the, not all, but some of them would help out. But that's where there's a new technology that's non-thermal called pulse field ablation, which is really high voltage for very short periods of time. And being non-thermal, we've been able to get epicardial transmural, still working on doing it safely and reproducibly. But, there's a lot of biophysical, and it's interesting if you know biophysics, because we couldn't figure out when we went to people, these clamps didn't work as well. But, humans have much more fat than even pigs, which is interesting because you wouldn't think, but our fat is quite different. And so I brought one of the engineers in from one of the companies, and I said, could you sometimes these devices aren't working. And all we did was calculate Ohm's law, because we knew what voltage we were applying, and we knew the resistance, because these clamps give you the resistance. And we just calculated Ohm's law. And he said 13% of the time, you didn't deliver any power to tissue, just by Ohm's law. And then we went back and did the experiment. We first had to find a model. So we went back to hearts that were turned out for transplant on humans. And guess what? He was exactly right. We proved, I thought, it's good for Ohm to know that his law did hold up. And it's all just basic physics, which, it really is. But that's, I didn't show that, but that was another thing. We couldn't figure out why, but it's human, the fat. And that's why I think electrophysiologists are a little lucky, because they don't have any fat inside the heart. So they don't have to worry about getting through that.
Other questions from colleagues? Dr. Abis, and I'm putting a trust for folks on Zoom. Dr. Abis.
And we appreciate the work that you have done for the surgical ablation of AFib. As you know, we have been doing this endocardially for the longest time, and exactly like you mentioned, pulmonary vein isolation by itself might not be the answer, especially endocardially. How do you think this field is going to evolve with the introduction of pulsed field ablation? In the past, we were hesitant to ablate the posterior wall because of course, the concerns about the esophagus with heat or cold. But now with pulse field ablation, we have been using it for about 1.5 years now, and we have a much lower threshold for using pulse field ablation for posterior wall isolation. And we don't have long-term results, obviously, but I'm suspecting that's going to be better than just pure pulmonary vein isolation. So how do you think this is going to affect your field?
Yeah, so the first answer is 95% of all surgical ablations we're not competing with the standalone. Okay, 95% are people that are sent to us. So a third of our patients have AFib, and as surgeons, as you know, still in the U.S., less than half are being treated, and of those being treated, very few are getting the maze I showed you, which we know works. Most are getting less invasive, a lot of pulmonary vein isolation, which has been, I just showed you one study for sake, but it's, how we do pulmonary vein isolation is way different than when you guys talk about it. When you do the wide area circumferential ablation, and having operated on so many patients from the EP lab, it looks like, someone put a grenade in the back left atrium. I mean, you get what we would, more of a convergent look. It's very extensive. And that was the problem with surgical PVI, because it's this clamp and it's very discreet, but it's too discreet. You need the whole area, and you guys know that the whole area is pretty arrhythmogenic. So first of all, pulse field ablation I don't think is going to affect the majority of our practice. For the standalone practice, I think there'll still be, I think that to me, just was in the EP conference, and one of the big hybrid EPs said that he hasn't referred a patient for a hybrid procedure in 6 months because of PFA. I think there's a perception that it's better, but you know, their early results have shown that it's similar, but it's safer and way quicker. So that I think it's going to expand the already large pool of people getting catheter ablation. And I think it will delay some patients. But I do think, you know, first of all, PFA surgically has the opportunity to let us do a complete maze with, you know, thoracoscopically on a beating heart, not on bypass, which I think may lower some bars of referral. I think there'll still be patients. But I think, one of my big emphasis is just get surgeons treating the AFib that's already referred to us. We have plenty of that and still not treating well. I think in the standalone, I think PFA will probably take more of the patients out. I think there'll still be, in my opinion, long-standing persistent AFib. I mean, I just did a load maze on someone who failed 2 ablations, has had AFib for 15 years and has left atrium that's 5 centimeters. I think those patients will still come. Should come to us. But still, even before PFA, most electrophysiologists didn't refer many patients to surgery. It's a handful. And in the defense, not all, I think surgical results have been variable between centers. But we just did there's been 2 multi-center trials, prospective trials with independent for adjudication. We're going to just finish the second one 6 months ago. But using multiple centers, not all St. Louis, because everyone's like, no one gets those results. We had 90% freedom in a year in a complicated cardiomyopathy group of patients with, like I said, most with long-standing, all with long-standing persistent AFib. So it can be done, but I think you're right. It's going to be, it's an interesting technology that I think has got to improve results both in catheter and surgery. And it may allow for some really interesting, procedures where either, there could be thoracoscopically, if we could get a full box, which is what some of these hybrids are doing, and let you guys kind of complete the rest, it might be. There's a lot of strategies. I mean, I think we'll get a lot more data. There's a lot of stuff for the young fellows to do now because there's still so many unanswered questions. But it's a really interesting technology. I think it's going to make a big impact.
I guess the conversion procedure plus endocardial PFA would definitely, help you.
Well, if you did convergent with a technology that worked better like PFA, if you use that on the surgical side too, but there's not many devices yet out there.
Dr. Damiano, it's been a privilege and an honor to have you here. I want to remind the faculty, residents, and everyone that we're going to have a group photo with Dr. Damiano at the stairs afterwards. Also, you have an impressive legacy of career of 4 decades. I also want to invite the faculty and residents to read the patient experience. I did what Dr. Dunley did when he interviews candidates. Go and read the patient experience stories about Dr. Damiano. They're quite inspirational. It's not only your 4 decades of NIH funding, however, an inspiration and care for patients. We ask every visiting professor a question. What advice do you have for our faculty and learners?
Well, my advice would be for those of you that are, first of all, it's a great field. I mean, there's really no greater privilege than to be a surgeon. And, I was asked just before this to kind of look back and, to come in every day and help people. I mean, there's nothing quite like it. That you picked a great career to go into. I really urge you to, stay inquisitive and challenge the status quo, probably. And there's so many unanswered questions, whether it's AFib or so many other areas. And as surgeons, my one advice, you have an incredible and unique access to human pathology and human tissue that almost no one else has, and take advantage of that. But there's, and for those who want to become cardiothoracic surgeons, it's still it's a fantastic field. People say it's always changing, but it's amazing to see the transformation. But, that would be, there's a lot of advice, but, and then, find what you're passionate about. And it's not going to be what I'm passionate about or anyone else in this room, but find your passion and then pursue it.
Thanks for that. I'm going to invite our chiefs of PGY4 to give you a parting gift, if you have, please. Then we know there's a wet lab, Dr. Gallegos, what time is it, 9:30? Or immediately after the photos? What room do you know? Second floor. All right.
No, thank you. Hey, congratulations too on your. Nice to see you. I enjoyed you. Oh, that's right. That's right. Good to see you. Okay, oh, no, my pleasure. Okay, yeah, no, I'm used to that.
More photos, Dr.
Yeah. You know what, we need a selfie stick or something, yeah.